Hi, I'm Dan Gadara. I'm a dentist in San Diego County, and this is my E4D PlanCAD video channel. Today I want to talk about cementation strategy. I have a particular view towards this process, and I've come up with a widget that helps me to pull this off. So if you hang in there with me for a little bit, I'll show it to you, and whether you agree with my methods of cementation or not, maybe you'll find it helpful. I've come up with at least a couple of applications for it. I'm not going to talk about treating the internal surfaces of crowns, since there's so many materials out there that this is a topic unto itself. But I would like to mention that for all my silica containing materials, I like to try them in the mouth untreated first, and then at time of cementation, I like to treat the internal surface with Ivoclar's Monobond Etch and Prime. Don't forget, if you use this, that every material has its own protocol. Since I mentioned etching, I'd like to go off topic for just a sec. If you've relegated Empress to a material from the past, I suggest maybe you take another look at it, as some instructors at the Plan Mecca University in Dallas suggested a few years ago, and I'm really glad that I did. Empress really hits that sweet spot of strength, aesthetics, and etchability, to where it's now my go-to material for porcelain veneers, provided that the stump shade of the tooth that I'm working with isn't unfavorable to where it contraindicates the use of Empress because of its translucency. But as this article in the Australian Dental Journal indicates, because of the high lucite content of Empress, which creates a lack of homogeneity in its composition, Empress etches really well to where its surface looks more like an English muffin compared to most materials that look more like Wonder Bread. So back on topic. With regard to treating the teeth, a guiding principle for me is the belief that the integrity of the dentin resin interface is one of the most overrated entities in dentistry, and it must be established with attention to detail. Now, the treatment of dentin is a huge topic, but suffice it to say that I feel strongly, and the literature supports, that the use of a two-step etch and prime system preceded by a brief total etch and use of an MMP inhibitor creates the most stable, hydrophobic, plasticized dentin resin matrix. Now let's move on to the mechanics of cementation. The guiding principle for me in this respect is the belief that the worst time to remove cement is when it's not fully set. I believe this is true for both resin and glass ionomer cements. Now, I have absolutely no literature to support this, and I know not everything that makes sense is true. But I've come to think this way because if you think about the cements in the past, they went from a paste to sort of a doughy consistency to hard as a rock. Today's cements go from a paste to a brittle stage and then hard as a rock. So if you like the periphery and think that your cement is hard, you may be jumping the gun with regards to what's going on under the crown. Now, if I'm right, then the corollary to this is that the best time to remove cement is when it's fully set. Now, I like having some excess cement because with glass ionomer, I like having a barrier to my deeper stuff for moisture, and for resin cement, I like having a barrier for moisture and an air-inhibited barrier for my deeper cement. But leaving cement like that can be really problematic because this stuff can be tough to remove. So a guiding principle for me in cementation is don't let cement stick any place you don't want it to. So here's how we achieve this. To facilitate preparation of the crown, we like to put a handle on it. We're currently using Pulp Dense Pick and Stick. This has ideal stickiness at all times as long as the crown surface is dry. Since my assistant and I both have loops with headlamps, one of us will place Parkel's Blue Sep on the exterior axial walls close to the margin and up to the marginal ridges, especially at the interproximal contact areas. We then briefly dry it over a high-speed suction, drawing the separating media occlusively. Blue Sep is an alcohol emulsion. It's pretty volatile and dries quickly. Now here's the widget I was telling you about. A lot of people use autoclave Teflon tape to mask off adjacent teeth during cementation. This placement is easy in the anterior and the tape is fairly stable. Placing tape in the posterior areas can be difficult, especially when trying to mask the tooth distal to the cement site. The tape in the posterior is also easily dislodged. So I came up with this thing I call cement drapes. Here's how I make them. I take autoclaved Teflon tape and spread it on a flat surface. I have a bottle of Dent-Splice Alcoat that has green food coloring in it so I can see it, and run it across one surface of the tape. I pull it off the surface and put it in a new location. I let it dry and repeat this 2 more times. After it dries, I cut it up in approximately 1 centimeter pieces. I now have a piece of Teflon tape that has a dried hydrocolloid on one side that it's just waiting to suck onto anything that's moist, like a tooth adjacent to where I'm cementing. Now, if we're using resin cement, we place this after our brief total etch and before we place our MMP inhibitor / dentinal tubule coagulator. From there, it's either a glass ionomer or resin cement. If we use resin cement, we scrub with a 2-step prime and bond system, air thinning after each step, and light cure before cementation. I've used many brands and systems of resin cement over the years, and I've had great clinical success with Optibond XTR and Nexus 3 cement. This is Kerr's recent replacement for Optibond XTR Universal. I'm not really happy about this. I don't like hoping when I do dentistry, and I hope this isn't a step backwards. It's not just about bond strength or the way a material smells. I think it's very important that the dentin is well plasticized and creates a hydrophobic surface. Because of the cements we use, either Nexus RMGI or Nexus 3, we light cure the perimeter heavily, then let the internal cement that the light may not have gotten to proceed with its self-cure. So how long do we let our cement set up? Well, we wait about 7 minutes. I've mixed both of these cements in a dark room at room temperature, not body temperature, and 5 minutes seems to be sufficient, so I've given myself considerable room for error. Both of these cements are rock hard when we remove them, but that's not difficult because of our preparation. The nice thing is that they come off in big chunks. The tape partially pulls out by hand, the remainder with 2 or 3 flossings with a knot. I almost always finish in approximately with a perforated one-sided diamond strip with a dead center portion. If needed, minor marginal adjustments can be made with ultrafine high-speed diamonds and diamond-impregnated rubber abrasives on a slow speed. I particularly like Brasseler's points for this. The one modification to this protocol is for situations with very supragingival margins, such as an onlay or large areas of uncovered root. Here, leaving large bulk of excess cement is a mistake. I prefer to wipe away the bulk, leaving some excess before lighting, and using discs and rubber brushes on a slow speed for seamless margins. One more thing before I close. Another use for these cement drapes is for situations where you want to disturb an unhealed surgical site with an impression or reline. This is ideal for an immediate denture soft reline when sutures are still in place. The tape creates a barrier preventing material from entering the surgical site. If you dab excess moisture from the gingiva with a cotton roll or gauze, the tape stays put nicely and peels away from impression material or well-set soft liner. I found tape widths of 1/2, 3/4, and 1 inch are available. So I hope there's something I've told you today that you find helpful. Next time I'd like to talk about either the Ivocolor system or Emax Ceram, or maybe we'll talk about where we're at with CAD/CAM in our office now. It's been 7 years and a lot's changed. So until next time, I hope you thrive in your practice.